Welcome to Connecticut eHealth Podcast, educating, conversing, and connecting for better health. The Connecticut eHealth Podcast is a space where we get together with local and national experts, key stakeholders, and other individuals in the space of eHealth to discuss health information in Connecticut and around the country. This podcast is brought to you from the UConn Health Interoperability, Innovation, and Learning Lab, where our mission is to promote the optimal adoption and use of eHealth by providing education and engaging in conversation with leaders to create connections for better health. So let's sit back and get connected. Hello, this is Tom Agresta. I'm a family physician and a clinical informaticist at the University of Connecticut Medical School. And I'll be your host for this episode of the Connecticut eHealth Podcast. Today's guest is Dr. Bradley Richards, who has been the Chief Medical Officer at Connecticut's Department of Social Services since 2021. DSS runs the Medicaid program for the state. His educational background includes a BA from Furman University and his MD from Georgetown University School of Medicine. He completed a residency at Yale School of Medicine and Internal Medicine. He's previously held the role of co-medical director at Haven Free Clinic and is also Director of Primary Care Innovations Curriculum at the Yale University School of Medicine. Thank you for joining us, Brad. It's a pleasure to have you on today and to speak with you again. As you and I know, we've met each other around primary care innovation in the past.
Yeah, it's great to be here. Thank you so much for inviting me. Definitely an honor and privilege. And I think primary care innovation, definitely an area that we're both probably very passionate about still and interested in. And I think this conversation will touch on that in some way.
Yeah, absolutely. So tell us a little bit more about yourself, what you did at Yale and how you ended up at your current role as the CMO at our Connecticut DSS.
Yeah, I am still at Yale in some capacity, still doing some clinical medicine. And so I finished residency, was very fortunate to be able to stay on faculty in our Yale Primary Care Internal Medicine residency training program, where I had the pleasure of helping run our residency clinic, as well as kind of develop the curriculum you mentioned on primary care innovations. And ultimately, for me, I went and did an MBA. I'd gotten some advice from some mentors that I was thinking MPH, MBA. And I think what clicked for me was like having to help, kind of help run a clinic, recognizing the importance of how providers are paid directly impacts the type of care and the way we provide care. And so ultimately wanted to learn more about finance and accounting, which was really useful for me. And then I ultimately had the opportunity to join the Department of Social Services, especially in light of some of the work that's being done around development of a maternity bundle and thinking about opportunities for reforming our primary care payment systems. And so those were really exciting for me. And that's kind of what brought me to this current role. And I'm very fortunate that I continue to be able to work with residents, both in inpatient and outpatient setting. I really love clinical medicine and still get to see patients in some way, though it's obviously a little bit more challenging. I don't have my own patient panel anymore, which I miss, but I'm very glad to at least stay connected to patient care, because I think ultimately that should it really influence policy and the decisions that are being made around coverage and decisions around what we're doing for Medicaid members.
Yeah, those are excellent points, Brad. I mean, I know that I've stayed active in clinical care at a small percentage myself, in both teaching residents and also seeing my own patient panel, for some of whom I've seen for now 30 years. And in my role in informatics and advice that I give to various organizations at the state level, I know that it's really important to know, if you're making suggestions about changes, that you understand the impact of them and that you would feel them and experience them themselves. I'm sure that goes a long way towards making you believable when you communicate with your physician peers about Medicaid and the direction of Medicaid.
Yeah, I think that definitely it does help. And it's even, I've only been in this role 18, 19 months, but even in that time frame, kind of seeing the direct impact and also some of the challenges that current policies we have may cause on either providers or directly on our members or patients. And for example, we last year helped put in place new coverage through emergency Medicaid for people to have dialysis on an outpatient basis. And
Mm.
I'm actually working in the hospital this past, I think, March or April, and had a gentleman who otherwise wouldn't qualify due to his documentation status. And, it's a pretty small expansion. It's not a big population that's served by this coverage expansion, but I was able to help educate the folks at the hospital that, hey, actually, he can be discharged in the near future. We can get him access to dialysis underneath this kind of expansion of emergency Medicaid. That was really neat to be able to see kind of a change in policy since I started directly impact someone. The challenge is it's not great if the CMO of Medicaid has to tell people that this is a coverage benefit. As you can imagine, that's not a sustainable solution. So that also taught me, you can change policy, but if people don't know about it, sometimes it doesn't matter. So I think I definitely learned some lessons. I was glad to see it, but I definitely had a lot of takeaways from it as well.
Yeah, that's always a lesson to learn is that whatever you change, making sure that others are aware and actually want the change, is also really important. Can you roll through a little bit more of the details of what being the chief medical officer for DSS entails? What kinds of things do you do on a daily or weekly or monthly basis?
So I had the pleasure of and fortunate of getting to craft some of that. And there's lots of things I do, and some of them may be surprising, including occasionally I'm actually reviewing prior authorizations, which might seem strange, but all the way down to that level. But really, a lot of the bigger things that I'm very passionate about are payment reform initiatives, especially around how do we create equitable systems? How do we make our payment systems actually improve health equity? And those are levers that I think are really important. And often we don't always understand what we're doing. There's one of the challenges that I face, and I think we face, is that there's not always data about what's the best decision to actually drive better outcomes and around payment, especially. And I think it's something that I'm challenged with frequently in helping make decisions. I'm not the only decision maker. There's lots and lots of decision makers, and we actually engage a lot of external stakeholders in our work because, as you already alluded to, making decisions in a bubble often doesn't lead to the best results. And so spend a lot of time engaging with people outside of the agency to understand how we can make better decisions and more equitable decisions. And lots of other things. You're probably familiar, Tom, we have our medical ASO, behavioral health ASO. These are administrative service organizations. So we are not a managed Medicaid state. Managed Medicaid is when you have private insurance companies or private nonprofits that run kind of their own insurance plan underneath Medicaid. We operate as our own risk-bearing entity. So we have kind of the front face of Medicaid through our ASO. So again, and so we spent a lot of time working with those partners to help with policy implementation, communication, make sure we have enough providers. Spend a lot of time working with other sister agencies because, as you can imagine, there's a lot of opportunity for collaboration. Just because someone's on Medicaid now doesn't mean they're always going to be, and because someone's not on Medicaid now doesn't mean they're not going to be in the future. And so thinking about what's that ecosystem, including our Department of Public Health, Education, Department of Corrections, et cetera. So really trying to build collaborative opportunities for improvement and better data exchange, especially. There's just a lot of data, as you know, and as this kind of conversation alludes to, that we don't always put together, but can actually drive policy and our understanding of what we could do. As we kind of alluded to, I'm very interested in education in many ways. So we're actually working with the Office of the Governor to build out Office of the Governor's Fellows program. So we're hiring fellows to work with us at the state, non-clinical fellows right now. They're folks who usually are early in their career, to give them experience and really help with meaningful work that we at DSS and other agencies are trying to do. And that's been very rewarding and reminds me a lot of the medical education work I've gotten to do, is to bring in people who are very excited about learning and have their own expertise. And so that's been fun. And then I have a number of people that report to me and spend a lot of time thinking about our team structure. How do we, train people up? How do we give people opportunities? How do I make sure the people that are directly reporting me feel supportive enough, but have enough flexibility to flap their wings a little bit? So that's just a few. There's actually a probably longer list, unfortunately, or fortunately. but it's actually really neat. I'm just feeling fortunate I get to do clinical medicine at the same time, because it really, again, it's so important, I think, to be informed by that.
Yeah, it sounds like you have a wide array of duties, and my guess is that you also get called in during legislative session to, kind of represent ideas and important changes in policy or things that need defending in terms of what you're doing to try to improve healthcare outcomes, like you mentioned, the equity, et cetera.
Yeah, definitely during the legislative session, very busy time responding to queries from our legislative colleagues about what policies we may want to consider, what we're currently covering, doing analyses of what it might mean to make changes, having discussions. So very, very busy during that session. Maybe I didn't mention, I may have blacked it out from this past time, but yeah.
Yeah, well, I think you're coming up on a longer legislative session this next year. So you'll remember it again shortly, I'm sure. You mentioned that data is really critical for you in terms of, informed policy making and really understanding the implications of what's actually happening out there. And DSS does deliver a wide variety of not just healthcare services, but social services to the state. Can you talk a little bit about what your current data collection methods are and what's working well, what challenges you're having?
Yeah. So, and I'm not our kind of chief data officer, but it's something I'm very interested in, very passionate about. So we at DSS, like you said, we're not just Medicaid and CHIP. So I really sit mostly in the Medicaid and CHIP world but we offer oversee a number of other programs, a lot of other programs, in fact, including things like SNAP, temporary family assistance programs of cash assistance for electrical heating needs, et cetera. So there's a wide range. And so we pull in a lot of data. A lot of it comes in through our eligibility team when people start to enroll. And so we get information at that point in time. And then we may pull in other data along the way, depending on what services people are receiving. So in Medicaid and CHIP, most of the data we're receiving is through claims. So bills are submitted, those claims come in. We have a system that helps process those claims, the MMIS. And so our claims data is actually in a separate area from our eligibility data. And so combining that information actually is a process that we have to go through. And then we send a lot of the information out to our administrative service organizations to help us administer the Medicaid and CHIP programs, as well as several other initiatives. So the major data sources we have would be through eligibility. So people, again, enrolling in programs and the front face, and then through claims data. Again, there's other sources as well, but those are going to be the major ones. We don't receive much really, we're not really receiving clinical data on a wide scale. Some of our programs might receive some clinical data, but we're not really doing anything significant, and it's for a very small portion of the population. There's data that goes to our ASO partners on people who are admitted to the hospital or go to the emergency department. That data does go to them, but we don't really have records. We have very few labs. There are some labs that go to the ASOs, but again, what I mentioned in terms of eligibility data, which would include things like race, ethnicity, age, your home address, et cetera, anything you would normally collect on an eligibility form, and then our clinical claims. And that's going to make up the majority of the data that we're pulling in.
And you mentioned, that there's a lot you can do with that data, but obviously, if you're really responsible for the healthcare of patients, the ability to kind of have some window in, even in a de-identified fashion, on actual clinical data, so that you actually see outcomes that are not just sort of cost and event-based outcomes, but are more, I would say, in line with what you went into primary care for, right? Improvements in people's health, reduction in risk factors. What kinds of clinical data would you, like to be able to have access to, if it's set up securely, appropriately, and in all those ways that keep it confidential, et cetera?
Well, let me just, even before that, just say, like, what we're using now, like you alluded to, we're using proxies for clinical data, the claims data with, you have your ICD-10 codes on there that I'm sure we both are putting all of them on there that they always need to be. I'm sure, Tom, we always make sure all of them are billed 100%. And so that just tells you that, if you're relying upon providers to know how many people have diabetes, well, there's different ways you can get that. We also have pharmacy claims data. If someone getting a diabetes medication, you can kind of infer it. But if someone doesn't list diabetes, do we always know they actually have it, or pre-diabetes or hypertension, et cetera? And then if we're relying upon that type of data to know, like, is their blood pressure controlled? Well, when we look at blood pressure control just based off claims data, it doesn't look very good. But if you actually go and pull clinical data, it's much, much better. Like you're talking, it looks like 5 to 10% control, up to 60 to 7% when you actually go to look at the data. And that's, worrisome when you start thinking, well, I have to make decisions based off of claims data. And I would say it's useful. It tells us something, but I wouldn't say it's probably the data we want. And kind of your question is like, what would we be looking for? As someone that's looked at a lot of claims, a lot of clinical data, I'd say that's much more robust often. It also usually includes claims information, similar information on claims, and it's housed obviously typically in the EMR, but talking about actual knowing what someone's blood pressure has been is much more useful than knowing, did someone code it correctly as to having controlled blood pressure? Because then you can, over time, if I had the blood pressure, say you had my blood pressure in our system, and obviously guidelines change over time. And so blood pressure control, maybe 10 years ago, if I was a 85-year-old individual, we might have said, oh, great, 140 over, 9, less than, you're 139 over, 89, you're well controlled. And now we might say, well, you actually had a history of stroke, and we should probably try to get it a little bit lower than that. And we might actually set a lower blood pressure goal. And instead of relying upon claims data at the time, you could actually use that number, and you could actually change that in the system. You could go back and say, oh, 10 years ago, well, we might have said it was controlled, but if we want to rerun that now, we actually knew we actually can kind of control for the changes in clinical guidelines by having actual numbers. And I think that's useful for when you're looking for trends. And it's also helpful to be more precise, because how precise is it to know that someone coded uncontrolled blood pressure?
Well, yeah, and of course, you and I know that uncontrolled blood pressure can be 1 week's worth of lack of medication, and the rest of the time it's controlled, and it doesn't mean the same thing in all circumstances. And then, in many other circumstances, you wouldn't code for controlled blood pressure, and they may go in and out of control. So you raise excellent, points that kind of pairing some of these periods of data, these types of data, actually allows you to do, not just analysis of things, but I would imagine, especially with the size of the population, the Medicaid population, you'd be able to help clinicians, guide them as to where you see potential risks for patients better than currently exists, right?
Yeah, I think right now a lot of our risk modeling and predictive model is based off of claims, right? That's historically what we've done in as payers, which we're government payer and DSS, and that prediction is only as good as the data you're putting into it. And I think we just discussed how there's some challenges with some of that data. Now, we do have some useful information around historical utilization across large periods of time that you might not always have in the EMR. Now, some health systems and some EMRs are obviously more connected than others. And so that might be better. That might be able to be done at the local level as opposed to at the centralized payer level. But, we, with better clinical data, could probably do a better job of doing predictive analytics around, hey, this person's at, maybe they don't have uncontrolled diabetes right now, but we see some concerning medication utilization patterns. Maybe they haven't been picking something up as much, or they're picking up less frequently. Plus, historically, we know that their A1Cs crept up, a point over the last 6 months or something. And this tells us, based off of other data, that this person's at high risk for going very out of control or something. So we could help with that. But we don't really have that level of data. And so having something, diabetes, I think, is a great example where we probably could predict we could predict folks who might be challenged to be controlled for various reasons. So some of those might be psychosocial reasons that we're aware of and maybe not always in the provider's information, or the provider has information that we don't, that we can pull in, that we can help with that making that prediction and then provide that. I think that this goes hand in hand with really looking to make sure we're incentivizing providers in a way that's not just always activity based. So seeing as many people as possible. Obviously, this means making sure we're calibrating services in such a way that providers have the time and ability to really focus on those who need more time, which is a challenge, I'd say, in our current environment. If you have someone with poorly controlled diabetes, it can be harder to always spend the time that they might need with them because of, you often have appointments that are booked based off of, time slots as opposed to clinical need, which is very much a financial issue. And that's how our system has been built for a very long time.
Yeah, I agree. We need to rebuild that. So, Brad, this seems like a good time to take a brief pause and hear from our sponsor, Connie, the statewide health information exchange. We want to take this opportunity to thank Connie, Connecticut's official health information exchange. Connie was established in 2019 to oversee and provide services to support the exchange of health data in the state of Connecticut. Connie is an independent and not-for-profit organization. To learn more about Connie, please visit conniect.org or go to the show notes from today's episode. So, Brad, as we return, you mentioned needing more data. Well, one exciting piece of news in the last year is the emergence of a state-level health information exchange. The DSS has been very, very involved in helping secure funding for and helping to set up its sort of overall mission and helping to govern on its board of directors. And our state's HIE, Connie, is starting to move clinical data. And I wonder what you think about that from your DSS hat and from your clinical hat, and what do you think could be the value there for you?
It's huge value potentially. So I think our Commissioner Gifford, has been extremely supportive and I think has a deep knowledge of the impact of better data. And so is really wanting to be supportive of continue to make sure that one in the database claims data becomes available in the all payer claims database from Medicaid and CHIP data. That's very important that we're playing a part in that. And we've been working on including that information. And then in terms of value, a lot of things we already discussed, but we'll take it a little bit deeper, I would say. So thinking about value-based payment programs. So as we talk about getting to value, and that can mean a lot of different things, but often that means focusing less on volume and trying to get better quality outcomes, maybe saving money, maybe not all the time. Sometimes it's just really about improving quality, but keeping costs the same. Is how do we measure quality, and having better data from EMRs to measure that quality would be a really helpful point, because as we're going back to our hypertension control, it's hard to hold people accountable at the provider level. Imagine all the data. So right now we measure hypertension control. We have to go and pay a vendor to pull blood pressures from EMRs and interface with those EMRs. It's very expensive. So there's a cost to the system to do that. And it would be so expensive to do at the provider level. It'd be hard to say, like, does Brad Richards do my patients that I'm seeing have control? That would be extremely expensive to get a big enough sample size to do that at this point. But if that data is available through the HIE and we can tie it to a provider and the provider's organization or practice group, well, that becomes a lot easier if we can do it in a systematic way. And then we can actually say, okay, well, we have a pretty good sense that your blood pressures are controlled, and we're going to incentivize you in a certain way. We might reward the organization differently when you have better control, or your diabetes is better controlled. And so we're talking about outcome measures, those things become important when we can get better data on the incoming, as opposed to having to spend so many resources to pull it as we do now. So I think that's a simple one. Another one is policy evaluation. So as we implement policy, how do we know it's working? And I think we need better knowing when we make changes, does that change clinical outcomes? And we're really often relying upon our claims data to know. And I'd say that's a pretty mediocre way of doing assessment. And so policy would be much better informed by clinical data. And also, I would say by report, so there's something that the HIE and Connie may not be as helpful with, but I think we might have more room for capturing patient-reported experience and outcome measures that could be go through Connie or an HIE, or it could be if we have more resources because we're not having to, pay to collect blood pressure data, we could use those resources to collect member satisfaction data, which I think, as we're talking about health equity, well, if we can pay providers based off of outcomes, especially like things thinking about, did you feel discriminated against by your provider? Were you, welcomed? And, a bunch of other things that a lot of this still has to be worked out, but I think it provides more resources for us to try to expand that opportunity. As of right now, we're, using resources that otherwise we could direct otherwise.
Yeah. So you misaligned resources essentially, right? Where your ability to realign them to something that adds more value. And I really appreciate your thoughts on trying to get provider groups into a place where they actually have the time, resources themselves to kind of make patients much more engaged and participating in their care, as well as tracking that and giving people feedback on it and rewarding those organizations that do a good job on that. Because as you and I know, the literature and all the analysis of it is that when you really engage with patients from disadvantaged backgrounds, et cetera, they have much better health outcomes. They have lower costs to their care, and they have much better health outcomes and greater satisfaction. And boy, that's something that we can all get behind, I think. So Brad, tell us a little bit about what you would like to do to innovate care for the Medicaid population, and how healthcare data sharing might facilitate that or help that.
So in terms of innovating care, I think one of the things that we're trying to do, and I'll use the example of our maternity bundle that we're planning on launching summer 2023. So a bundle is, we're calling the bundle, but it's really broken into a couple different payment models. So historically, we've paid providers, you go to the provider, you get paid, the provider bills, they get paid for that. In maternity care, they do an ultrasound, they do Group B strep screening, visits, et cetera, you get paid for those encounters. So it's very much, again, activity encounter driven. The bundle you'll be paying a prospective, which means we'll be paying upfront for the care and basically it's going to be averaged for the care that's already being provided. So say I'm a certified nurse midwife and I've provided care historically. Well, we know what my prior spend was, and I can get that kind of upfront broken probably into chunks. We're still working on some of these details. So if you're listening to this in like 2024 and this is a little bit different, that's why, but just of note, that's kind of our plan, is to pay it upfront because we know providers have costs, and we know paying 18 months later may not work as well in the outpatient setting. So we want to make sure we're providing some financial resources, some capital up front, so that providers can operate differently moving forward. So this by itself, may not, just paying prospectively would be quite a change. But the other thing we'll be doing is setting a rate between the C-section rate and the vaginal delivery rate to really try to encourage more vaginal deliveries. I think it's pretty clear that in the United States, there's way more C-sections that are done that are necessary. And so that's important because I think most providers are trying to do the right thing. I think financial incentives are not at the front of everyone's mind, but often those things can kind of push you one way or can push your organization one way or another. And so basically we want to push towards vaginal delivery when appropriate. And then we'll also be doing something called a retrospective reconciliation, which is like shared savings, where providers who are able to reduce costs, and we're actually eventually going to include the newborn costs like NICU stays, because it's very clear that prenatal care done well can improve the health and well-being of the newborn. And that's very expensive resources. NICU care is very, very expensive. And so we can especially identify individuals at high risk early on, especially those who might have significant and persistent mental illness or substance use disorders, and get those individuals the care they need to have healthy pregnancies and then healthy deliveries and hopefully healthy babies. I think those can be win-wins across the board. And so how we pay for care is extremely important. And I think pushing it more flexibility to providers, holding providers accountable for outcomes is important. And where does this, and so as we talk about outcomes, we come back to data because we need better data, and talking about where do we get that data from? Well, if we can get it through the HIE, well, that's going to make it much easier for Medicaid and CHIP for us at the state to actually monitor those outcomes and then either pay providers accordingly and reward them or potentially penalize them slightly for those things. And so a lot of this, we're still working on the details, but you can just see how better data, and not just from Connie HIE, even some of our sister agencies. So let me just give you one example. Department of Public Health has a lot of really important data, vital statistics data. They capture a lot of survey data around pregnancy. And for us to collaborate further, I think will actually enhance a lot of the services that we're trying in the new maternity bundle by bringing in that data, clinical data from Connie, bringing in survey data from the Department of Public Health and vital statistics data. So it just, I think, makes a lot of sense. It's just hard to do. There's a lot of challenges with data sharing. I think you're well aware of them.
Absolutely.
But they're worth working on because in the long run, they really can drive significant change, and it's slow, but it can be really meaningful. So let me stop there.
That's a great example of sort of a robust, way of approaching and thinking about changing things that I agree with you is a really win-win-win across the board. Because if you got, you get that money up front, then you can invest in social workers and other professionals to collaborate on the care that's going to even offload some of that work from, as you and I know, let's let everyone rise to the level of their license and their capacity to care for patients, and that'll extend what the physicians and the clinicians can do substantially, right? I know you've been very interested in sort of primary care innovation, and talk through a little bit of some of the ideas that you think about that might occur in primary care that would be parallel to this, idea around maternity care.
And so I'll just caveat this and say we're in the process of evaluating our existing primary care programs. So we have kind of basic primary care, which there's no enhanced fee. It's just our typical rates. There's PCMH, which requires providers to go through a PCMH designation process to get an enhanced rate. And then there is some quality measure payments on the back end. And then we have PCMH Plus, which folks had to apply to be part of, and has for FQHCs participating a per member per month care coordination payment. Plus you get your base payment rate, which is enhanced as is in PCMH. And then there's shared savings on the back end, which has quality measures tied to it. So if you don't meet certain quality measures, you won't necessarily get those shared savings. And so that's what we're currently doing. And we're looking at them both to say, is what we're doing now meeting goals, including equity goals, which I think when these were built, that wasn't necessarily at the forefront, though I think they were considered. And so thinking about it through that lens. And then we've done relatively extensive stakeholdering to get feedback from community members, our members, providers, hospitals, FQHCs, and a few other groups to really understand where should we be going? What are some of the perspectives from the community, as well as providers and patients and members, to know what should be our focus? And so we're in the process of kind of finalizing that. We brought in an external vendor to help us, and then we're planning on presenting that publicly and kind of looking at what's next. I would say in general, our interest is making sure that providers can be accountable for patients and members. So from put on my provider hat, accountability is often challenging. I mean, I wanted to be accountable, but if someone didn't show up for an appointment and I'm busy seeing other patients, do I always have time to call them? I'm trying to, right? But it's not always, it's hard. And so unless you have really great systems in place, and I think our systems aren't always built for this for various reasons, because we often incentivize as volume over value in our current payment model, it creates challenges with being accountable and feeling like you really can do a good job with accountability. So I think our goals are, we want to focus on equity and as part of our primary care reform work. And then we want to make sure providers have the tools to be accountable and feel that they can help members, and also make sure that members have the opportunity to select the provider they want. So, patient member choice is very important. And then giving provider flexibility, I would say, is also really important in light of a larger overarching equity goal. And so what does that look like? I don't know yet. There's a lot of interesting models out there. If you look at the Medicare Advantage space, which people will criticize some of the costs that go into Medicare Advantage, but I would say if you drill down into some of the specific areas, you'll see some really interesting payment models and provider models out there that have, I would say, provided pretty high satisfaction when you look at things like Net Promoter Score. And I think the opportunity for Connie to help to be involved. I mean, when you look at those platforms, what do they do well? They collect data much better than what we do. And they measure it very closely, including the experience of the people that are getting care in those models. And I think we can do the same thing. We just, it's not free to capture member satisfaction. You think doing a survey is easy. It's very costly. Because to get an equitable sample, you have to spend a lot of time, and we can try to get email surveys, but really ultimately a lot of it is telephonic. And if you want good data, you have to pay to get that data. And right now right. What's our data system now? Well, it's a claims data processing system. That's what we've invested in. And if we want to change that, then we have to think about investments for the future, including making sure that we're utilizing data from sources like Connie to help us with our outcome measures, but also capturing additional information on patient and member satisfaction. And also, did someone talk with you about pregnancy prevention if you're an 18-year-old individual that could get pregnant? And, we can ask members, like, did someone actually talk with you about it? Because I think as providers, sometimes it's easy to click things off and how well did we actually talk about it, right? It's like, are you interested in getting pregnant? Click, I've been to provide, I've been paid myself. Like, you get this checklist. Sure, they asked me, but did they ask me really? I think. And so we want to know, we could ask patients, did you feel like someone actually went over this with you? And, obviously there's pros and cons of doing that, but I think we can empower patients and members by putting more things in their hand and then tying payment to that, because that they have choice. And then we incentivize providers to try to be more patient-centered, which, I think we can all do a better job.
Yeah, you mentioned kind of like being able to actually capture data from patients, and as you probably know, Connie is going to be actually rolling out a patient-facing the capacity for patients to log in on a web portal and also to actually get in through an app, mobile apps. And I think that your idea of like being able to collect, not just for the purposes of running the Medicaid program, but I actually think for research purposes, it's also important. And it also, makes me think about, the sort of remote patient monitoring activities that we might really kind of collect data on, that range from telehealth activities to sort of digitally collecting, continuous glucose monitoring and other things like that are really sort of, I'd say, places where there's opportunity tremendously to innovate, but are going to be data intensive and require collaboration from multiple different organizations to get them to occur.
Yeah, definitely. I mean, I think we probably don't know what to do with that. I mean, I know in practice, it's hard to even know what to do with continuous glucose monitoring data sometimes when you have a large number of patients that are on them all at once. And then at the, coming to the payers, so putting on my Medicaid and CHIP hat, I don't even know if we'd want that level. We might want to know what's your time in range or something like that.
Right.
Something like that. And if it's like, oh, great, you're like 90% in range, great. That's probably what we want. We don't want every single glucose measure, because then it's a lot of data, and we also have to figure out what to do with it, which we can do. And I think it's better to have it and to parse it out than not have it. But I think there's going to be some challenges along the way with figuring out how to utilize it most effectively.
Yeah, the difference between data and information and knowledge is going to be critical that we really work on. So this has been an absolutely, fascinating conversation. And Brad, as you know, we could probably talk for hours, but can you give us any kind of final words of wisdom for the listeners?
I don't know how wise I am at this point. I'm still pretty early in my career-ish, I would say, and definitely early in my state government career. But I would say always keep people at the center of decision making as much as we can, and including in payment models, always think about how can we make sure that we talk about being patient-centered. How do we make them part of both the business model, the financial model that drives better patient-centeredness, as well as then decision-making for providers. So I think that is one thing that I try to keep close to the heart. And I would say we all should as we try to make better policy. And it's much easier when you're actually interacting with the people that their policy is impacting. So for those who are interested in this space, and our clinicians, try not to give that up, try to continue to do it. It seems so important to help drive better conversations and better decisions.
Yeah, I completely agree. I think that my patients, I often when I'm seeing a patient and have a student with me, et cetera, I find that the patient is a far better teacher than myself.
Yeah.
They have greater sense of wisdom to give the learners than I do often. And they are great at helping shape, what should happen in order for them to get better care.
Yeah. I mean, we're all patients, right? We're all just people, whether we're providers or whoever. And I think being humble about that is important, and trying to make sure we keep that in front of our minds as we're practicing and making decisions. And ultimately, we probably can hopefully craft care that we all want to receive, and craft policies that we're all happy to receive for ourselves and our families and loved ones.
Well, that's wonderful to leave our listeners with. Thank you so much.
Thank you.
As always, wishing you the best of health. Your host, Tom Agresta.